Good evening, everyone. So, this week we'll be continuing our lecture on leprosy, and the topic that we will discuss this week in this masterclass is histoid leprosy. Now, histoid leprosy is one of the unusual forms in which lepromatous leprosy or a variant of lepromatous leprosy presents. Okay. Now, there are multiple unusual forms of leprosy, and if time will permit in the future, we will surely discuss what are the unusual manifestations of leprosy. But the most important unusual manifestation of leprosy that we need to understand is histoid leprosy. So during this masterclass, during this lecture, we'll discuss what is histoid leprosy, the clinical manifestations, and all the different unique aspects about histoid leprosy and what makes it separate from other forms of Ridley-Joplin classification of leprosy, and what are the common characteristics of histoid leprosy as compared to the other parts of the spectrum. So without much further ado, let us start our discussion this week on histoid leprosy. Let's move forward. Histoid leprosy is characterized by spontaneous cutaneous and or subcutaneous nodules. Just remember that in histoid leprosy there is spontaneous presentation of cutaneous and subcutaneous nodules, and the nodules are larger. They will be plaque over an apparently normal skin. Okay, you have to focus on these words. Apparently normal skin. The background skin appears normal. It does have lepromatous infiltration, but it's not clinically apparent. So the background skin will appear normal. So let's say if this is a patch of skin of the patient, you will see a nodule here, which is of histoid leprosy, while the background skin would appear normal, and you will have a histoid leprosy lesion here. Now, in patients who undergo irregular or inadequate therapy, mostly if they are on monotherapy with dapsone, they are more prone to develop histoid type of leprosy. Or patients who have been infected with drug resistance to dapsone, in which the lepromatous bacilli has resistance to dapsone, or if you have a mutant bacilli, these all predispose a patient to develop histoid leprosy. It may occur de novo prior to MDT, that means before you even start MDT. See, you will understand, you will know that a leprosy bacilli is resistant to dapsone only when you start MDT, isn't it? So it can appear de novo as a presentation with histoid leprosy. Histoid leprosy comes in the bracket of multibacillary leprosy, that means towards the lepromatous pole, in which the body has large number of Mycobacterium leprae. It is also seen as a presentation in borderline leprosy, lepromatous leprosy, even indeterminate leprosy can lead to histoid leprosy. Now, just a brief summary that indeterminate leprosy can lead to nearly all forms of leprosy except the polar forms. So, polar tuberculoid or polar lepromatous. Okay, it can also lead to histoid leprosy. So there's some kind of switch happens in the host immunity against M. leprae bacilli that kind of triggers indeterminate leprosy to form any other spectrum of leprosy, be it BL, BT, TT, or BB. But they are if there's certain trigger, it can push the patient to develop histoid leprosy. Okay, let's move forward. Now, in clinical features, we see multiple lesions. So, histoid leprosy is multiple lesions are involved. There are multiple nodules and plaques over the whole body, especially over backs, buttock, face, extremities, and bony prominences like elbows and knees. Individual nodules are described as firm, reddish or skin colored, dome shaped. So, a dome shape, or oval, well demarcated papules with shiny and stretched overlying skin. The overlying skin is stretched. In fact, in biopsy, you will see epidermal atrophy. It is stretched to that extent. So, what you have to do is just imagine a nodule growing. And when a nodule grows and grows, it will push the epidermis and it will stretch and thin out the epidermis. They have a constriction at the base. So, you can see that at the base, it is constricted. In fact, some of the nodules can be pedunculated. Okay, they can be pedunculated, and the surrounding skin is normal clinically. So clinically it looks like any normal skin normally in normal people, but if you take a biopsy you will find M. leprae there also. Let's move forward. Histoid leprosy rarely go into reactions, and reactions like ENL are rare. We know that ENL is mostly a feature of lepromatous pole towards the lepromatous pole, but histoid Hansen is also towards the MB leprosy pole. But reactions are rare, especially ENL. But ENL may occur after starting MDT. The moment you start MDT in histoid Hansen, you make sure or be very careful that the patient can develop ENL. Another unique feature is persistence of eyebrows. We know that metarosis is an important clinical component of lepromatous leprosy. Important clinical component of lepromatous leprosy. And histoid Hansen is also a component of lepromatous leprosy, but the eyebrow will be persisting. Clear? Nasal mucosa and cartilage is usually spared, and we know that in lepromatous leprosy they are involved. In fact, you have tests like nasal blowout and nasal mucosa scraping to look for AFB. The general health appears good. Okay, patient doesn't appear sick or severely clinically involved. Let's move forward. A term that has been described in clinical features is the histoid facies, or the facial presentation, or the facial uh, appearance in histoid leprosy. Histoid facies are described as classical presentation of histoid leprosy. There are two types have been described. You have the first type and the second type. The first type looks more like lepromatous leprosy or the leonine facies of lepromatous leprosy. The first type is old, wrinkled skin, atrophic facial skin, and features show off a burnt out LL. So you will see kind of a diffuse, shiny, scaly, atrophic skin over the face with scanty eyebrows. Now remember, we have told that in histoid leprosy there's persistence of eyebrows, but in histoid facies or the first type, you can have involvement of eyebrows along with depressed nasal bridge and eye involvement. So if you can remember correctly, all these features look like lepromatous leprosy. But how will you differentiate? Patient will have nodules and plaques, thick nodules, skin nodules over the body. We are just talking about the face here. The face or the first type can mimic leonine faces of the lepromatous leprosy. Clear? Now coming to the second type of histoid faces, it will mimic the typical histoid nodules and plaques. So you will see histoid lesions over an apparently normal facial skin without any other manifestation of leprosy. So just to recap, in histoid faces, which is a classical presentation of histoid leprosy, two types are there, first type and second type. And first type shows features similar to lepromatous pole, while the second type shows features more characteristic of histoid leprosy. Clear? Let's move forward. So we have talked about the clinical features. Now let's make the diagnosis of what are points you have to keep in mind while making a diagnosis of histoid leprosy. Now the diagnosis is largely clinical. It is so clinically characteristic that the moment you see the patient, the diagnosis of histoid Hansen's is made. What you see is histoid lepromas. Now histoid lepromas are those nodules that you see. Okay, along with histoid faces, which we have described as type 1 and type 2. Okay. If we do a slit skin smear of the nodule, you will find abundant uniformly stained AFB, acid-fast bacilli. So you will see an acid-fast bacilli that is abundant, a large number of AFB or large number of M. leprae, which are uniformly stained by acid-fast stain. Globi formation is rare. Now remember, globi is more a feature of lepromatous leprosy. Clear? But in histoid leprosy, you will see singly lying or solitary M. leprae, multiple M. leprae filled in the foamy histiocytes. When we do an AFB stain on the slit skin smear, we find long, strongly and uniformly stained bacilli. If we do a slit skin smear of normal skin, you will see paucity of AFB. That means AFB are present but very less in number as compared to the nodules, and that is why the surrounding skin appears normal. If we do skin biopsy, characteristic features are seen, which we will discuss in detail in subsequent slides. Let's move forward. Hi, hope you're enjoying this video. I know it's a long video, so I thought I'll give a certain break after listening to such a long videos that I make. If you think that these videos are helpful in your residency, do consider becoming a member. You can opt for Sapphire membership or Ruby membership. I would prefer it to be a Sapphire membership, of course.
You get access to longer videos, bonus contents, extra information to make things more interesting, and to cover each and every aspect of the topic that we are discussing. Okay, so I think that's enough of a break. I should continue with the video, and you should listen to the other person at the bottom right corner tell you different topics of dermatology, venereology, and nephrology. That being further said, let's continue with the video.
Now, if we do slit skin smear from the nodule, you will see abundance of organisms occurring singly. That means they are isolated, they are separately from each other because global formation is rare. Global formation does occur, but they are rare. Okay. In fact, Whedon's textbook of pathology mentions one case in which the author has seen, and they have included that photograph. I've also included that photograph, and we'll discuss. Each Lepre bacilli is solid and uniformly stained. So what you will see a uniform staining. And you will see long bacilli, longer than the normal M. leprae bacilli that we see, along with tapering ends. So the ends are taper, which we call as fusiform body. So lepra bacilli becomes fusiform. We know that normal bacilli are rod shaped, so they don't have that kind of tapering ends. But in slit skin smear, the M. leprae bacilli are fusiformly arranged. That is why some authors believe that it's because of mutant bacilli, mutant M. leprae bacilli, that leads to formation of histoid leprosy rather than lepromatous leprosy, because there is some issues with the M. leprae bacilli, some genetic difference are there leading to formation of histoid leprosy. Let's move forward. In the previous slide, we have mentioned that histopathology of histoid leprosy is very characteristic. So we'll spend some time to understand what all features we see in the biopsy. Okay. In biopsy, you will see a well circumscribed growth in the dermis. Growth in the dermis. Okay. And this is one of the cardinal features. There will be predominance of spindle-shaped or polygonal cells, that means of different shapes, and they are filled with large numbers of AFP. Grain zone is present, especially in about 50% of the cases, you will find a grain zone. But the grain zone is thinned out, it's thinned. Why it is thinned? Because of the fibrohistiocytic morphology of histoid leprosy that is continuously pushing around it. Okay, so what actually happens is if we just draw a diagram, so this is epidermis, this is dermis, you will see a dermal growth which is pushing the epidermis around it. Okay, so the epidermis will become like this. Okay, and in between you will see a thin grain zone, a thin grain zone. Here, a thin grain zone, and when the when the evolving granuloma or the evolving growth, well circumscribed growth, pushes around the surrounding tissue, it leads to a formation of pseudo capsule. It's not a true capsule, it's a false capsule, in which it is because of the compression of the collagen bundles in the dermis. Clear? Let's move forward. Now let's understand the individual foamy histiocytes. Okay, these histiocytes are numerous, thin, spindle-shaped histiocytes forming interlacy curly bands and whorls. Take some time to read this sentence and make sense of it. Numerous, multiple, large numbers, spindle-shaped histiocytes. So this is the word that you have to be very careful about. Spindle-shaped histiocytes are seen in histoid leprosy, while a fusiform M. leprae is seen in histoid leprosy. Clear? So we have spindle-shaped histiocytes in which you have fusiform longer uniformly stained AFP, and these spindle-shaped histiocytes form interlacing curly bands and whorls. In fact, the pattern is described as story form or pinwheel-like. So like this, okay, or like this. Imagine seeing a Van Gogh painting. So it looks like that. Okay. These individual spindle-shaped histiocytes have oval and lightly stained nuclei. And as the lesion ages, as it grows older, the histiocytes become spindle shaped because that's how it matures. The collagen also increases, and there is fibrosis in the growth. When fibrosis happens because of age, this is what you see as white streaks in dermoscopy. And because of this fibrosis, on biopsy, it looks like a fibrohistiocytic tumor. And because of that, the term histoid leprosy has been coined. It looks like a growth of fibrous tissue, okay, like a fibroid. Okay, let's move forward. Now, the differentials include infiltrated and indurated nodules, which can be seen in dermatofibromas, dermatofibrosarcoma protuberans, xanthomas, keloids, to some extent hypertrophic scars, neurofibromatosis type 1, 3, and 4, reticulohistiocytosis and other histiocytic disorders, cutaneous sarcoidosis, skin metastasis, post-Kala-Azar dermal leishmaniasis, disseminated molluscum, and disseminated histoplasmosis. These are some of the differentials. Of course, you have a large list of differentials regarding subcutaneous and cutaneous and superficial nodules, overlying and apparently normal skin. But these are at least 10 differentials of histoid leprosy. Let's move forward. Now, treatment is easy for histoid leprosy. You just have to continue MBMDT, but for the sheer number of M. leprae, you have to continue it for at least 2 years, and preferably till the smear turns out to be negative. So, in histoid leprosy, requires a prolonged treatment with multi-drug therapy at least for 2 years until the smear turns negative. But always remember, whenever you start MDT, you can predispose the patient to develop ENL. So keep that in mind. After treatment, the histoid leprosy patient shows variable response and there can be resistance to treatment. Remember, in the initial few slides, we discussed that resistance to treatment is actually one of the reasons that a person can go towards histoid leprosy. Let's move forward. Now, what is the significance of histoid leprosy, or how histoid leprosy is a bit different from other forms of leprosy that we usually study in Ridley-Joplin classification? First of all, you have a fusiform, elongated, uniformly staining bacilli. That makes it different. We have told you that the bacilla is thinner, is longer than the normal M. leprae and has tapering ends, while normally we see bullet-shaped or rod-shaped M. leprae bacilli. There is globule formation is a bit decreased in histoid leprosy, while in lepromatous leprosy, you see a lot of globule formation. Resistance to dapsone therapy. We know that dapsone therapy resistance is a feature of histoid Hansen's. Now, in pathology, it has been shown to have highly active lepromatous process. That means there is tendency to form lepromatous leprosy at a localized point, not as a diffuse formation of lepromatous leprosy like we usually see in polar and subpolar LL, but as a nodular growth in histoid leprosy. Some authors regard this as a form of stable leprosy. Why? Because the histoid lepromas or the nodules or papules that we form, we see, resemble TT leprosy, but the differences are that they are formed majorly of macrophages, spindle-shaped foamy histiocytes, and a large number of M. leprae, but they are localized like TT, but discretely present over the whole body like LL. Clear? And others regard histoid leprosy patients to have better cell-mediated and humoral-mediated immunity to trap the mutant bacilli. So the theory of mutant bacilli is also there in histoid leprosy. That is what makes it a bit different from kind of leprosies that we see. With that, I'll finish the discussion on histoid leprosy, and this video covers more or less each and everything about histoid leprosy. In fact, we have covered a lot of different topics in this short series that we had started on leprosy the second time. The first time we have covered about what five, seven, about seven, eight lectures. Then we have covered about 10 or 12 lectures more. So go through these lectures if you find them useful. We have a separate playlist by the name of Leprology on the channel. You can go through these kind of lectures. Let's move forward. So these are the reading recommendations, but if you go through this video, that's more than enough you need to know about histoid leprosy. Again, telling you about this membership, consider becoming a Ruby member. But remember that after a few months, I do plan to discontinue Ruby membership and continue with Sapphire and beyond. So if you find these videos helpful and if they are helping even a little bit in your residency, do consider becoming a member. Especially Sapphire member, they have better access to different kind of useful information, extra content, longer videos, and also they are eligible to answer for polls while deciding the newer topics. Let's move forward. So with that, we finished this week's discussion on histoid leprosy. I hope you liked it. You are free to comment below in the comment section. Any doubts, you can put a timestamp and comment your doubt, and we can have a short discussion there. And any suggestions, queries can be put in the comment section. If you want, you can send me a separate email, but I prefer the comment section. So I'll not take further much of your time. I'll finish this lecture. Adios and bye bye.